Hello, my name is Rebecca Sternshine. I'm a member of the Pulmonary and Critical Care Division here at Brigham, and I'm going to be going over some critical care board review questions today. I have no disclosures to share, so let's jump in with the first case. This case is a 45-year-old gentleman. He has a history of hypertension, diabetes, a recent viral URI, and he comes in with 24 hours of worsening dyspnea. He has a fever with a Tmax of 38.7, and he's placed on 40% FiO2 by face mask. He's a little hypotensive. His blood pressure is 99/54. He has a leukocytosis with a white blood cell count of 19. And his ABG is written here. His pH is 7.30, PaCO2 is 30, PaO2 is 67, and his bicarb is 15. And on the right here, you see his chest x-ray. I'm going to take a pause here, think about the ABG and the chest x-ray and what that shows. So he has a pure metabolic acidosis. He has a pH that's low and a PaCO2 that's low as well. And he's hypoxemic with a PaO2 of 67 despite being on 40% FiO2. On the chest x-ray, he has a right lower lobe infiltrate. This patient is admitted to the ICU. He's placed on broad spectrum antibiotics, given IV fluids, and the FiO2 is increased to 60% by face mask. 6 hours later, he seems more tired and breathless, but he remains lucid. His ABG at this time is 7.25, 35, 87, 15. Our first question is, what is the most appropriate next intervention for this patient? Is it A, intubate immediately for hypercarbic respiratory failure and begin assist control ventilation? B, decrease the FiO2 for possibly causing an increased PaCO2? C, begin non-invasive positive pressure ventilation? D, decrease the IV fluid for a possible congestive heart failure exacerbation? Or E, cannulate for extracorporeal membrane oxygenation, or ECMO. So I'll pause here for a moment. Think about this. So the correct answer is C, beginning non-invasive positive pressure ventilation. So we're going to start talking a little bit about non-invasive positive pressure ventilation. There's evidence supporting the use of non-invasive in a variety of settings. First, since the 1990s, it's been shown that non-invasive positive pressure ventilation can positively impact patient outcomes for patients with an acute exacerbation of COPD. These patients have hypercarbic respiratory failure. It leads to decreased rates of intubation and shortened hospital length of stay and lower in-hospital mortality. Second, again beginning in the 1990s, evidence looked at the use of non-invasive ventilation for cardiogenic pulmonary edema. And while earlier data were mixed, a recent Cochrane systematic review from 2019 demonstrated that there's a benefit to using non-invasive in this setting. Specifically, it's been shown to decrease intubation rates and in-hospital mortality rates. Finally, since the early 2000s, the use of non-invasive positive pressure ventilation in acute hypoxemic respiratory failure, as opposed to hypercarbic respiratory failure, has been examined. And again, here it's been shown to decrease intubation rates and in-hospital mortality. Non-invasive is not ideal for every patient, so it's also important to consider contraindications. So the only absolute contraindication for non-invasive positive pressure ventilation is a cardiac or respiratory arrest. Relative contraindications include concern for inability to protect the airway, inability to fit the mask, either due to facial hair, facial fractures, or anything else, inability of the patient to tolerate wearing the mask, copious secretions or recurrent vomiting, and recent upper airway or upper GI surgery. So let's go through the other answers now that we learned a little bit about non-invasive positive pressure ventilation. So A is too aggressive for the first step. It's not necessary to do first. It's better to first try less invasive interventions. Additionally, in A, it says hypercarbic respiratory failure, and we mentioned that here as well in option B, causing an increased PaCO2. But this patient only had a PaCO2 of 35, which is not elevated. So he did not have hypercarbic respiratory failure. Additionally, the interaction between oxygen supplementation and hypercarbia is only an issue for those with obstructive lung disease. C is the correct answer. D is incorrect because IV fluids are necessary for this patient who probably has sepsis, and you can manage IV fluids with non-invasive positive pressure ventilation. The two are not incompatible. And finally, E, this is too early in the course of this patient's respiratory failure to use ECMO. This is really a consideration when hypoxemia is refractory and the patient has had a number of other interventions that have failed. So our learning objectives for this first question on respiratory failure, we learned first that non-invasive positive pressure ventilation can help to avoid intubation in patients with acute exacerbations of COPD, cardiogenic pulmonary edema, severe hypoxemic respiratory failure, and contraindications for non-invasive include the absolute contraindication of cardiac or respiratory arrest, and then a number of other considerations, including need for airway protection, inability to fit the masks, and unstable hemodynamics. So let's move on with this patient. Unfortunately, he does not get better. And despite the non-invasive, he deteriorates, is intubated for progressive refractory hypoxemia, and is diagnosed with ARDS based on the Berlin criteria defined in 2012. This is summarized below. This is a process that is acute in onset, less than 7 days. His P to F ratio is less than 300. He has bilateral pulmonary opacities, and they're not fully explained by cardiac failure or volume overload. You're called to evaluate the patient for agitation. His current ventilator settings, he's on assist control ventilation. His tidal volume is set at 450, which is 6 cc's per kilogram of ideal body weight. He has a PEEP of 10, respiratory rate of 14, and an FiO2 of 60%. His pressure versus time waveform is displayed here, and I'll give you a moment to look at that. The question now is, what is occurring at the arrow in the bottom right-hand corner here, and what is the best way to address it? Is it A, ventilator malfunction, and you should bag the patient and change the machine? B, patient ventilator dyssynchrony, and you should sedate the patient more heavily? C, air hunger, and you should increase the tidal volume? D, air hunger, and you should increase the inspiratory flow? Or E, auto PEEP, and you should increase the set PEEP to match the auto PEEP and lessen his work of breathing? I'll pause for a second to think about that. So the correct answer is D, air hunger, and you should increase the inspiratory flow. So let's first talk about air hunger. Air hunger occurs when the patient wants more flow than is being delivered. As you can see in the pressure waveform, which is red at the top of the screen, in the first breath that's delivered here, there's a gray arrow pointing to a downward deflection during that delivered breath. That downward deflection is the patient trying to breathe during the delivered breath. Remember, a patient initiates a negative pressure breath, and that's why the pressure dips downward when that patient is trying to breathe. On the flow curve of that same first breath, you see that the flow increases because the patient is delivering him or herself more flow during that delivered breath. If you increase the flow rate, which we've done here in the second breath, that resolves this type of patient ventilator dyssynchrony. So let's go through the other answers now that we know this. For answer A, there isn't any indication of vent malfunction to suggest that we need to change the machine. For answer B, this is true partially. This is a form of patient ventilator dyssynchrony. But sedating the patient should never be your first choice of action when you find that there's dyssynchrony. You should explore other solutions before increasing the sedation. For C, this is again partially correct. This is air hunger, but it's more likely a flow problem than a volume problem. And particularly in this patient who has ARDS, we should be maintaining lung protective ventilation with a low tidal volume. And so we should try all other options before we liberalize the tidal volume. D is correct. And then E, this one is about auto-PEEP. So there's no indication of auto-PEEP on the waveform that we were given. And additionally, auto-PEEP would be a process that we wouldn't see during inspiration, but rather during expiration. So I'll talk a little bit more about auto-PEEP here. Auto-PEEP occurs when the flow does not return to zero by the end of expiration. So we have pressure, flow, and then volume curves here. And we can see on the flow curve here, the green curve, inspiration is above the line and expiratory flow is below the line. So flow into the lungs is above the zero line and flow out of the lungs is below that zero line. So what we see here is that at the end of every expiration, flow is still happening. It's not returned to zero. And what that means is there's incomplete emptying or gas trapping when that expiratory flow is still occurring when the next breath starts. And this can lead to dynamic hyperinflation, which is demonstrated in the volume waveform, which is the blue line at the bottom. And what we see here is progressively increasing end expiratory volume, which is dynamic hyperinflation and can have severe consequences for the patient, increasing the work of breathing for the patient, increasing the risk of barotrauma, increasing dyssynchrony, and potentially also leading to hemodynamic compromise. So our learning objectives for ventilator dyssynchrony are twofold. One, we learned about air hunger, and that we should think about air hunger when the pressure tracing scoops downward during the delivered breath. We should address this by increasing the inspiratory flow, and remember not to reflexively increase sedation when we see this type of dyssynchrony. Additionally, we should think about auto-PEEP when the flow tracing does not return to baseline at the end of expiration. Remember, this is a process that we can see during expiration and not inspiration. This can cause increased work of breathing, dyssynchrony, predispose the patient to barotrauma, and impact the hemodynamics. So we'll keep going with this case because he's not finished yet. After 6 days, your patient is finally improving. He no longer has a fever, he's hemodynamically stable, and he just had a chest CT that demonstrated improvement in his bilateral opacities. His current ventilator settings are assist control ventilation, tidal volume of 450, so he's on 6 cc's per kg about ideal body weight. His PEEP is 6, his respiratory rate is 10, and his FiO2 is 40%. You're called because his vent is alarming for high pressures, and the respiratory therapist tells you that the peak inspiratory pressure has acutely increased from 22 to 34, and that the plateau pressure has also increased from 15 to 28. So the question is, which of the following is the most likely cause of that high pressure alarm? Is it A, his endotracheal tube migrated into his right mainstem bronchus? B, his endotracheal tube is kinked? C, he has a mucus plug in a main airway? D, he's developed an acute pulmonary embolism? Or E, this is just a part of the natural history of ARDS? So pause for a second. The answer is A, that his endotracheal tube migrated into his right mainstem bronchus. So let's start by talking about airway pressures in general. The peak airway pressure is calculated as the sum of the airway resistance pressure and the plateau pressure. As a reminder, airway resistance pressure is calculated by multiplying flow times airway resistance. And plateau pressure is calculated as the tidal volume divided by the compliance. Remember, this is measured with an inspiratory hold maneuver when the flow is 0. So as you can see, peak airway pressure incorporates both resistance and compliance, and so it can be elevated as a result of abnormalities in either one of these measures of pulmonary mechanics. So when we think about the elevated airway pressure alarm going off, we can either think about it being due to a high peak pressure with a high plateau pressure, or a high peak pressure with a normal plateau pressure. So on the left-hand panel here, we see when we have a high peak and a high plateau, that suggests that resistance is normal and is not the thing that is driving that peak airway pressure to be elevated. Instead, it's that compliance is poor. And causes of poor compliance include main stem intubation, such as in this case. This patient, remember, was just transported to the CT scanner. Heart failure, pulmonary fibrosis, pneumothorax, abdominal compartment syndrome, circumferential burns of the thorax. There's a number of different things. This is not an exhaustive list that can cause poor compliance and therefore a high peak pressure and a high plateau pressure. On the other hand, if we had a high peak pressure but the plateau pressure was normal, this would indicate that that peak pressure was being driven higher by the resistance. And then we would be thinking about causes of poor resistance, like bronchospasm, mucus plugs, and kinked endotracheal tubes. So if we look at the questions again, the first answer, A, is correct, because as we know, that would cause both an elevated peak airway pressure and an elevated plateau pressure. B and C both would cause increased resistance and would have normal plateau pressures. In D, this actually would not have a significant immediate effect on peak or plateau pressure. And E, the natural history of ARDS does not include sudden worsening of compliance, so sudden like in this case. And in fact, over time, compliance usually improves, particularly in this instance where we had other indicators that the patient was improving from a clinical standpoint. So our learning objective from this question about elevated peak airway pressures. When the vent alarms with an elevated peak airway pressure, use the plateau pressure to determine whether the issue is airway resistance or lung compliance. If the plateau pressure is normal, think about causes of increased airway resistance. And if the plateau pressure is elevated, think about causes of decreased lung compliance. Next question. A 67-year-old woman with a history of hypertension, hyperlipidemia, and diverticulosis presents to the ED with abdominal pain, altered mental status, and hypotension. Her vital signs are significant for some hypotension, tachycardia, heart rate's 110. Her respiratory rate's 16, so maybe she's breathing a little fast. She's satting 94% on 4 liters. She's febrile, 101.2. She weighs 70 kilos. On exam, she's ill-appearing, she's drowsy, difficult to arouse, has mottled extremities, and has diffuse involuntary guarding of her abdomen. She gets a CT scan, has a perforated sigmoid colon, and is sent to the OR 2 hours after she first arrived in the ED. She has a laparotomy. She's noted to have a grossly contaminated abdomen, but the surgeons are able to repair the perforation and clean the peritoneal cavity. She's sent to the ICU for post-op management. In the OR, she received 4 liters of lactated ringers, and she was given 1 dose of ceftriaxone and 1 dose of metronidazole at the start of the case. This was 2 hours after she arrived in the ED. When she's transferred to you, she's hemodynamically stable. Question is, which of the following is true regarding antibiotics in this case? Is it A, antibiotics must be continued for a total of 14 days? B, her chance of dying in the hospital is the same as it would have been if she had received antibiotics earlier in the ED, since both times were in the first 6 hours after presentation? C, antibiotics may be stopped after a total of 4 days. D, her mortality will improve by continuing antibiotics until 2 days after the resolution of fever, leukocytosis, and ileus. Or E, the ceftriaxone should be discontinued and metronidazole monotherapy should be continued for a total of 5 days. I'll give you a moment to think about that. The correct answer is C. So let's talk a little bit about sepsis. So based off of the Surviving Sepsis guidelines, we have some best practices that for care of patients with sepsis, and these include blood cultures, ideally drawn before antibiotics are given, early broad spectrum antibiosis, measurement of a lactate level and a repeat if it's high, giving 30 cc's per kg of crystalloids if the patient is hypotensive or if the lactate is particularly elevated, and using vasopressors to maintain a goal MAP greater than or equal to 65. Antibiotics in sepsis, we know, improve mortality. But a recent study in 2017 in the AJRCCM looked at 35,000 patients who were all given antibiotics within the first 6 hours of arrival to the ED. And he demonstrated that the timing of antibiotics impacts hospital mortality even before that 6-hour mark. So their adjusted in-hospital mortality differed based off of every 1 hour difference in the timing of antibiotics. And when we think about that with our patient, she was given antibiotics after the 2-hour mark. So her adjusted mortality was around here, odds ratio here. And if we had given her antibiotics earlier, potentially that could have been lower. Antibiotics and their use in intra-abdominal infections. So in a study that was done in 2015 and published in the New England Journal, they looked at patients with complicated intra-abdominal infections. This means gross contamination of the peritoneal space, just like our patient. They compared a short course of antibiotics that was defined as either 4 plus or minus 1 day versus a variable long course of antibiotics where the stop date was determined by resolution of physiologic abnormalities, including leukocytosis, fever, and ileus. And they showed that there was no difference in the composite outcome, which was a combination of surgical site infection, recurrent intra-abdominal infection, and death. This has been incorporated into guidelines regarding antibiosis for complicated intra-abdominal infections. As long as surgical decontamination is accomplished, it's recommended to treat for a short course of 4 to 5 days, unless, of course, the patient is clinically decompensating and or has evidence of an active infection. So we'll go through the other answers here. There's no benefit to continuing antibiotics for a total of 14 days. B, if she had received the antibiotics earlier than that 2-hour mark, or greater than 2 hours because she entered into the OR at 2 hours, her chance of dying in the hospital would be lower. We saw that based off of that first study we discussed. C is the correct answer. D, we saw in the second study that we discussed that this approach does not improve outcomes compared to shorter defined courses of antibiotics. And E, metronidazole monotherapy is not an acceptable empiric antibiotic regimen for intra-abdominal infection. So our learning objectives for intra-abdominal sepsis as a review. Patients with sepsis, in-hospital mortality increases with every 1 hour delay in antibiotic administration. And this is true even when antibiotics are administered within 6 hours. Additionally, after obtaining adequate surgical source control of a complicated intra-abdominal infection, treating with antibiotics for a fixed short course of 4 plus or minus 1 days is acceptable and has been shown that there's no difference in a composite clinical outcome compared to longer courses of antibiotics. Let's move on to the next question. Here we have a 72-year-old man who has a past medical history of hypertension, renal insufficiency, hypothyroidism, moderate COPD, and peripheral vascular disease. He's now post-op day 1 from a FEMPOP bypass. He was transferred to the ICU intubated because he was slow to wake from anesthesia, but was extubated yesterday afternoon, post-op day 0. His medications include an opioid PCA for pain, metoprolol for blood pressure control, levothyroxine for his hypothyroidism, and he received furosemide times 1 dose. His social history is significant for the following. He is a high-level executive in the financial industry. He has a history of 45 pack years of cigarette smoking, and he quit 1 month ago. He regularly has 1 to 2 drinks with dinner, admits to sometimes having more, but never has ever had any alcohol withdrawal. He also reports a remote history of cocaine use. His last use was 40 years ago and currently reports no illicit substance use. You're asked to come and evaluate the patient because he's become restless. The ICU nurse tells you that the patient did not sleep last night and was drowsy this morning, but now he's agitated and combative. You look at his vitals. He's afebrile. He's hypertensive above his baseline. He's tachycardic, but in normal sinus rhythm. His respiratory rate is 20, so he's tachypnic. He's satting 98% on room air. You review his labs. He had a urine tox before his operation that was negative. And yesterday, he had a TSH that was normal, a sodium that was normal, a creatinine that was mildly elevated from his baseline, and a normal white blood cell count. On exam, he's awake and alert. He's not diaphoretic. He's speaking in full sentences. He doesn't have very good attention. You don't notice any facial droop. He's moving all 4 of his extremities. He doesn't have a tremor or tongue fasciculation, and he has a clean surgical site. The question is, what intervention would have been most likely to prevent delirium in this patient? Is it A, use benzodiazepines for sedation in the ICU, B, standing high-dose opiates for pain control, C, prophylaxis with haloperidol while in the ICU, D, nighttime dexmedetomidine while in the ICU, or E, use of the ABCDE bundle in the ICU. We'll pause for a moment. The correct answer is E, using the ABCDE bundle. So we'll go through the answers first on this one. So both benzodiazepines and opiates can perpetuate delirium, especially in our older patients. Prophylaxis with haloperidol and dexmedetomidine have been attempted, but have been shown to be not effective in decreasing delirium in the ICU. On the other hand, the use of the ABCDE bundle has been shown to be effective in decreasing prevalence of delirium in the ICU. So let's talk a little bit about delirium. First, delirium is a syndrome. It's characterized by 5 different elements in the DSM-5. Disturbance in attention, a disturbance in cognition, development over hours to days, that fluctuates, and that's a change from baseline. It cannot be explained by a pre-existing condition. And finally, there must be evidence that the disturbance is due to a medical condition, substance intoxication or withdrawal, and a medication side effect, or a medication side effect. There are a number of predisposing factors for delirium, including advanced age, underlying dementia, a number of other components listed here. The impact of delirium in the ICU specifically is significant. It's been found that it's an independent risk factor for mortality among intubated patients in the ICU. Their mortality is 3 times higher at 6 months. It also is associated with fewer ventilator-free days, 5 days less on average, higher hospital costs, and 9 times higher incidence of cognitive impairment at the time of hospital discharge. Studies of delirium in the ICU have demonstrated that it's frequently multifactorial and often relates intimately with pain and agitation. Many of the interventions that patients experience in the ICU inherently cause one or more of these entities. And so this concept map helps to explain why optimizing pain, agitation, and delirium is such a complex process, and is not surprising that there isn't a single solution that we have found so far. What we do know is that the best treatment for ICU delirium is prevention, and always, if possible, treat the underlying etiology. How do we accomplish prevention? So far, we have not found any evidence for any pharmacologic agent that works well to prevent the development of delirium. We've done trials in 2018 of both dexmedetomidine and antipsychotics as prophylactic measures, and both of these demonstrated no effect. However, a study in 2016 showed that an ICU bundle protocol can decrease prevalence and duration of delirium in the ICU. And this is the bundle here, A, B, C, D, E. A standing for spontaneous awakening trials, B, spontaneous breathing trials, C, the coordination of both A and B, as well as the choice of sedating agents, D, delirium assessment and monitoring, and E, exercise and early mobility. And what it means to have a bundle protocol is that this is something, all of these components, all of these elements need to be addressed every single day in every single patient. And when that is done, that's when we can decrease prevalence and duration of of delirium in the ICU. So our learning objectives for ICU delirium, twofold. One, in mechanically ventilated patients in the ICU, delirium is an independent risk factor for mortality, and it is associated with increased hospital and ICU length of stay and cognitive impairment at the time of discharge. It's significant. And two, while there's no clear evidence for pharmacologic prevention of delirium, use of the ABCDE bundle can decrease prevalence and duration of delirium in the ICU. Question 4. We have a 73-year-old man with a history of prostate cancer who collapses while boarding a bus in a crowded urban bus terminal. Bystander CPR is begun, transit policeman arrives, attaches an AED which recommends shock, and discharges, and he has return of spontaneous circulation. The patient is brought to the closest hospital, remains unconscious but with a stable blood pressure. Upon arrival, he's emergently taken to the cath lab. He has a suspicious non-obstructing plaque in the circumflex, and he's transferred to the ICU with normal BMP, CBC, and coag panel. Our question is, what's the best next step to improve the outcome for this patient? Is it A, a stat head CT to rule out CNS catastrophe? B, refer for hyperbaric oxygen for possible hypoxic brain injury? C, begin external cooling of the patient to 32 degrees Celsius for 12 hours? D, begin external cooling of the patient to 36 degrees Celsius for 24 hours? Or E, hold a family meeting to relay his poor neurologic prognosis and discuss withdrawal of care? Take a moment to think about that. The correct answer is D. So let's talk a little bit about targeted temperature management. There's a class 1 or strong recommendation by the AHA from the 2015 guidelines that suggest for comatose, out of hospital, post-cardiac arrest patients with ROSC, we should do targeted temperature management with a goal temperature of 32 to 36 degrees Celsius for at least 24 hours once the target temperature is reached. This is a change from the prior set of guidelines, which recommended 32 to 34 degrees Celsius, after a study that we'll discuss in a few minutes that showed that there was no difference in outcomes between patients being cooled to 34 versus 36. The contraindications for targeted temperature management are all relative contraindications and include active non-compressible bleeding, pregnancy, and hemodynamic instability. And institution by institution, you may have different contraindications that are specific to a particular location. How do we accomplish targeted temperature management? Many places use external cooling devices such as this one, where pads are stuck to the patient and have circulated temperature controlled fluid running through them. You need to have a continuous temperature monitor, so not an axillary temp, but something that measures core temperature, like a bladder probe. And then that relays information to a temperature feedback device that is external to the patient that then automatically adjusts the cooling pads to maintain that target temperature. Why do we do targeted temperature management? So in 2002, there were 2 landmark trials published in New England Journal that showed that cooling improves survival and improves neurologic outcome. When we think about the other answers, the STAT head CT with no focal neural deficits, this is probably low yield. There is no indication for hyperbaric oxygen. This is incorrect because of the timing, should be at least 24 hours. This is correct. And finally, in patients who are candidates for targeted temperature management, the recommendation is that neuroprognostication occurs 72 hours after the patient returns to normothermia. Thinking about prognosis after a rest, there's a lot of different markers that we have for poor neurologic outcome, and we can look at these at different time points after an arrest. But the AHA recommendation is to wait 72 hours after normothermia is achieved to examine and assess patients. And additionally, not to use a single modality of testing, but rather multiple modalities of both testing and exam maneuvers to predict neurologic outcomes. So here are our learning objectives for targeted temperature management. We'll remember that targeted temperature management improves outcomes in patients who remain unconscious with ROSC after out-of-hospital arrest. Its improvements in survival and neurologic functions that we found. Additionally, targeted temperature management with a goal of 33 degrees Celsius does not confer a benefit compared to 36. And also neuroprognostication cannot be performed when the patient is hypothermic. It should happen 72 hours after their normothermic. We have an 81-year-old man with a past medical history of hypertension, diabetes, and mild emphysema admitted with pneumonia. He's mildly hypotensive, tachycardic, and hypoxemic, 92% on 10 liters. He's febrile as well. His white count is 15, his creatinine is mildly elevated from his baseline, and his glucose is 220. Which of the following is true? Hyperglycemia in the critically ill is associated with increased mortality. Targeting tight glucose is associated with a mortality benefit compared to a goal of less than 180. Targeting tight glucose is associated with shorter ICU length of stay. Hyperglycemia is only problematic for critically ill patients with diabetes. Episodes of hypoglycemia when targeting tight glucose control are insignificant as long as you adhere to protocols. The answer is A. Let's talk about hyperglycemia in the ICU. Multiple studies in the early 2000s, showed that hyperglycemia is associated with worse outcomes in a variety of different populations of patients, including patients after MI, stroke patients, ICU patients, and this includes a diverse array of ICU patients, both with and without diabetes, and trauma patients. And so based off of all of this, the question arose, does tight glucose control in the ICU mitigate this risk and improve mortality? And the answer is no. Based off of a trial from 2009, the NICE Sugar study, an RCT with 6,100 patients actually showed that tight control was associated with higher mortality and increased incidence of severe hypoglycemia. So if we look at these other answers, A is correct. B is the opposite, that tight control is associated with increased mortality. C, there was actually no difference in the ICU length of stay based off of the level of glucose control. D, incorrect, because hyperglycemia is associated with mortality in all ICU patients regardless of the presence or absence of diabetes. And E, we saw that episodes of severe hypoglycemia occur more frequently when we have tight glucose control. Our learning objective here is that tight glucose control is not recommended for ICU patients has been shown to be associated with increased mortality. Instead, the recommendation is for a target glucose of less than 180 in critically ill patients. A 47-year-old woman with mild bronchiectasis is admitted to the ICU with hemoptysis. She estimates that she's produced about 600 cc's of bright red blood in the last 5 hours. She's coughing intermittently and has dried blood on her lips. She's hypotensive, 100/60. Her heart rate is 110. She's tachycardic. She's tachypnic to a respiratory rate of 26. And she's breathing 90% on a 100% non-rebreather. She's afebrile. Her chest x-ray, which is here on the right, is read as stable compared to her baseline. And her ABG shows 7.54, 25, 67, 21. The question is, which of the following is the best next step? Should you, A, intubate her immediately with a double lumen endotracheal tube and call a thoracic surgeon to take her urgently to the operating room? B, initiate non-invasive positive pressure ventilation for her hypercarbic respiratory failure? C, send her for an urgent CT chest to identify the source of the bleed? D, perform nasotracheal intubation immediately? Or E, intubate her immediately with a single lumen endotracheal tube and perform a bronchoscopy? Pause for a moment. And the answer is E. So we'll talk a little bit about hemoptysis. Remember that the lungs have a dual blood supply, both from the pulmonary artery and the bronchial artery. The pulmonary artery system is a low pressure system. The bronchial artery system is a high pressure system. The majority of hemoptysis is actually from the pulmonary artery system, that low pressure system, and is not life-threatening. Hemoptysis that is life-threatening, most of the time, 90% of that comes from the bronchial artery circulation. Our definition of life-threatening hemoptysis is variable. It can either be based off of the total quantity of blood, so greater than 150 milliliters in 24 hours, or the rate of bleeding, greater than or equal to 100 milliliters per hour. The etiology of hemoptysis is very variable. The most common causes are bronchiectasis, infection, especially tuberculosis when we're looking at epidemiology worldwide, and fungal infections, and also malignancy. And this is a very much not exhaustive list of examples of things that can cause hemoptysis. Management of hemoptysis is important to know a couple of pearls. So we should always place the patients with the bleeding side down because gravity isolates blood on that bleeding side only, and we don't have cross-contamination. Endotracheal intubation should be performed with the largest bore tube. That would allow for both diagnostic and therapeutic bronchoscopy and also facilitates better suction and clearance of the airway if there's bleeding. Bronchial blockade can be useful in that it can isolate bleeding and protect the contralateral side. An additional benefit is that you may get some hemostasis. And finally, the use of a multidisciplinary team, IR, interventional radiology, interventional pulmonary, thoracic surgery, these are the people that need to be involved to obtain definitive intervention for bleeding. But again, notice that a lot of these interventions rely upon knowing which side of the lung is the source of the bleed. So that's also an important thing to do early on. So when we look through our answers, A, a double lumen tube is actually smaller bore than single lumen, and so this should not be used up front because of our goal of using the largest bore ET tube. Non-invasive positive pressure is contraindicated here because this active hemoptysis raises concerns for airway protection. So this would fall into our relative contraindication category for non-invasive. Sending her for a chest CT would not be a good idea. This is an unstable patient and you would be sending without a secured airway and then asking her to lie flat, which would be dangerous. Nasotracheal intubation is also not conducive to using a large bore tube, so you wouldn't be able to pass the therapeutic bronchoscope through this and wouldn't be as good of an option as E, which is the correct answer. So our learning objectives for hemoptysis. Remember that most hemoptysis is not life-threatening and originates from the pulmonary artery system, which is low pressure. When hemoptysis is life-threatening, 90% of that bleeding originates from the bronchial artery circulation. And the most common etiologies are bronchiectasis, infection, and malignancy. Urgent management considerations for patients who have life-threatening hemoptysis include prioritizing interventions to localize the bleeding side, so that's bronchoscopy often, positioning the patient with the suspected bleeding lung side down, and intubation with a large bore endotracheal tube, ideally size 8 or larger. Those are all the questions that we have time for today, and please feel free to email the course directors with any questions. Thank you so much.